Hi, I'm Christina Tremblay, and I'm a research associate working at the MNI, affiliated with McGill University in Montreal. And I will present you the result of the first part of my study, including people with a family story of Alzheimer's disease and Alzheimer's disease patient, which focus on the atrophy progression patterns in both of these groups and their relationships with different neurotransmitter receptors and transporters maps. So this study was made possible thanks to the collaboration with members of the FHAD and AD research group. I have nothing to disclose. So it is now well known that there is a long preclinical phase before developing Alzheimer's disease, which include changes in brain structures. And there are different factors that can influence these changes and put you more at risk of developing Alzheimer's disease, such as being a carrier of one or two APOE4 alleles, or having a parent or a sibling with Alzheimer's disease. And there are many studies about the brain structural changes in APOE4 carriers, but the structural changes in people with a family story of Alzheimer's disease is still unclear. In Alzheimer's disease, there are different structural brain measures that has been used as a proxy for atrophy, including deformation-based morphometry, or DBM, which is a measure of the deformation of the brain relative to a specific template. So typically with DBM, expansion is observed in the ventricle in Alzheimer's disease, and contraction or atrophy is observed mostly in the temporal lobe, but it's not only restricted to this lobe. So why some regions in Alzheimer's disease are more susceptible to show atrophy is still a matter of debate. It seems to be influenced by different factors, including the distribution of receptors and transporters in different brain regions. So different receptors seem to play an important role in Alzheimer's disease, such as the noradrenergic, dopaminergic, and serotonergic receptors. So for example, serotonergic receptors, including the 5-HT6 receptors, have been proposed as potential target to find new treatment for the cognitive deficit in Alzheimer's disease. So to better understand the relationship between the atrophy in the brain and different neurotransmitter receptors and transporters possibly implicated in Alzheimer's disease or in people with a family story of Alzheimer's disease, we first determined the patterns of atrophy progression in both groups using structural MRI from 3 different databases: the Montreal Adult Lifespan Study, ADNI, and AD. And we included the longitudinal data up to 4 years from ADNI and AD. Then we verified the regional distribution of different neurotransmitter receptors and transporters were related to the atrophy progression patterns observed in this group. We decided to use DBM measure as a proxy of structural changes. Briefly, we used the ENS longitudinal pipeline with the T1 MRI to create deformation-based morphometry maps for each subject at each time point. And we performed quality control to exclude maps with abnormalities in the DBM preprocessed images. And we used the Kaman Atlas with 448 cortical regions to parcellate the brain. And finally, we use longitudinal combat to regress out the scanner effect. So after the pre-processing, we ensure that the 3 groups, including control, people with a family story of Alzheimer's disease, and Alzheimer's disease, were similar relative to age, education, and sex at baseline. So in total, we include 116 control without a family story of Alzheimer's disease, 153 people with a family story of Alzheimer's disease, and 156 people with Alzheimer's disease in our study. As expected, Alzheimer's disease patients had a lower MMSE and MoCA scores, in addition to be more likely to carry 1 or 2 APOE4 alleles. So they also had a slightly higher depressive scores, but none of the patients was diagnosed with depression. So it was also an exclusion criteria. And for the group with the family story of Alzheimer's disease, they had a slightly but significant lower score than control at MoCA, in addition to have more carriers of 2 APOE4 alleles compared to control. So for the atrophy progression analysis, we use mixed model with post-hoc tests to compare the group with the family history of Alzheimer's disease and Alzheimer's disease with the control group. So we conducted the analysis region-wise using the Common Atlas, and we corrected for multiple comparison using FDR correction. So for the atrophy progression, we look at the interaction between group and age in a linear mixed model with random intercept and slope, and with group, age, sex, education, APOE4 status, BMI, and interaction between APOE4 and age as covariate. And for the correlation analysis, we use Pearson correlation between the atrophy progression and 7 different brain maps of receptors and transporters reported in a paper from Justin and Son in 2022. And finally, we tested the significance of each correlation against spatial neural distribution using BrainSmash. And we found a similar pattern of atrophy progression compared to controls in the group with a family history of Alzheimer's disease and Alzheimer's disease. Interestingly, some regions show a positive atrophy progression in green in the figure, and others showed a negative atrophy progression in blue. So in total, in Alzheimer's disease, there were 24 regions showing a significant positive atrophy progression. And this region were mostly part of the cingulate cortex, occipital, temporal, and parietal lobe. And 10 of this region also showed a significant atrophy progression in the group with the family history of Alzheimer's disease. And several regions also show less atrophy progression in Alzheimer's disease, mostly in the temporal and frontal lobe, suggesting a ceiling effect, most likely because of the advanced age of the group. And 11 of this region also showed less atrophy progression in the group with the family history of Alzheimer's disease. Afterwards, we look at the relationship between this atrophy progression patterns and 7 different receptor and transporter brain maps. And we found one significant and negative correlation between the atrophy progression and the serotonin 5-HT6 receptors map in both groups. But we found no other significant correlation between the atrophy progression and the other receptors or transporter distribution maps. In conclusion, we found that individuals with a family history of Alzheimer's disease show neurodegeneration in specific region also affected in Alzheimer's disease. And we also observed that regions with lower atrophy progression, most likely reflecting a ceiling effect, also have higher density of serotonin receptors in both the group with the family history of Alzheimer's disease and Alzheimer's disease, suggesting that serotonergic neurons might play an important and particular role in the neurodegeneration observed in Alzheimer's disease and in people with a family history of Alzheimer's disease. So thank you for listening, and to all my collaborators. More results from this study will come soon thanks to this collaboration. And please feel free to visit my poster for more information.